The Hopkins Eating Disorders Program has been in existence for close to 40 years and was one of the first specialty programs for the treatment of eating disorders. We are located within the Johns Hopkins Hospital, which means that we have access to all medical specialists and the ability to manage patients with severe medical complications of eating disorders. We treat patients from ages 12 to 80, and both males and females. Eating disorders are behavioral problems. We know that treatment needs to focus on helping patients to change what they do. You need to, in some ways, act your way out of a behavior, out of a problem that you essentially acted your way into. And people don't always understand that. They may feel that the treatment should focus more on root causes or on understanding where the eating disorder came from. But these disorders tend to take on a life of their own over time, and therefore it's important to change first in some ways and understand second. The Hopkins approach is a team one. Treatment occurs under the supervision of a multidisciplinary psychiatrist-led team. And each patient meets with the full team on a daily basis. The focus of treatment for eating disorders at Hopkins is on normalizing eating behavior. In the case of patients who are underweight, restoring them to a normal weight. We know that starvation increases preoccupation with food and weight, and therefore it's impossible to recover from anorexia unless you reach a minimal normal weight. So if a patient is admitted to the inpatient level of care, initially the focus is on helping them block eating disordered behaviors, establish more normal eating patterns, start weight restoration if they're underweight. And once those goals are achieved, they will transition to the day hospital or partial hospital, which is fully integrated. In other words, it occurs in the same place, treatment is occurring by the same team, but the difference in day hospital is the emphasis shifts to relapse prevention. And there, patients are involved in daily meal preparation, in eating meals in different social settings. Family starts eating meals with patients, initially on the unit, then increasingly during time off. And patients who are adults stay in our residence. We have a staffed overnight residence for adult female patients. The Jefferson House is located 2 blocks from the hospital and is a supervised house where patients who are being treated in the partial hospital program spend the night and can spend days off as they taper out of the program. What the Jefferson House offers is a more real-world, home-like environment in which patients can practice newly learned eating skills that helps ease their transition back to home.
In the past, parents, particularly mothers, have been blamed for causing eating disorders. There's really no evidence for that, and we take pains to relieve the sense of parental guilt.
Parents play a very important role. They play a role in the recognition of an eating disorder, in the treatment of an eating disorder, and in relapse prevention. And it is very important for family to be involved in treatment as much as possible. In fact, they're an integral part of the treatment team. So we work very closely with family and help them, essentially help their child or their loved one to both achieve recovery and, more importantly, to maintain it after they leave the hospital-based program.
Patients often don't feel ready for treatment. The behaviors that take place during the course of an eating disorder are reinforced and rewarding, even though that's a little unusual to think about, that something like vomiting or overexercise or severe dieting might be rewarding. Nevertheless, in ways that we don't quite understand, those behaviors become rewarding, so it's hard to give them up.
Ambivalence about treatment is perhaps a cardinal symptom, one could argue, of anorexia nervosa, so that it is typical of patients to not feel ready to change when they enter treatment. And what we see clinically is that as patients change their behavior, they become more ready or more motivated for recovery. So although we often hear from patients, I need to feel motivated before entering treatment. The reality is actually the opposite. The more we help patients change what they do, the more recovery feels like something that's achievable.